Okay, I'm recording tonight's lecture because I've got a pretty wicked sore throat and I just don't think I'm going to make it to the 6 o'clock hour. Therefore, everyone will be marked here. And I want to point out that there is a final exam study sheet attached to this week's module. And we have two modules today, plus a discussion number 5. And that is about pain and what is your threshold of pain, excuse me. So in talking about pain, research indicates that the nature, assessment, and treatment of children's pain has increased exponentially over the last 2 decades, meaning that there's been a lot more work, studies, research done on pain assessment and how to relieve it and so forth. Pain remains one of the most misunderstood, underdiagnosed, and often undertreated or untreated medical problems, particularly in children. And that's pretty sad, thinking that pain is something we can control with Tylenol and analgesics and morphine and so forth. Pain is something that no individual in the hospital should be experiencing. It is subjective to the individual, and it is also difficult to accurately assess, and often confused with fear and anxiety over a medical event. Some children have reported that their tummies hurt. They're feeling pain in their head. And it could be because they're missing a loved one or they're fearful of what is going to happen while they're in the hospital. What is pain? According to the International Association for the Study of Pain, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential damage or described in terms of such damage. Pain is a unique personal experience. So what pain you may feel may be of a different level and tolerance than the next person feels, with individuals varying widely in their perception and tolerance of pain. Pain duration, in other words, that length of time. Acute pain is pain of brief duration, which goes away with treatment or healing and can be caused by injury, surgery, illness, trauma, or painful procedure. Chronic pain, on the other hand, exists beyond the expected time of healing, and it persists over time, meaning chronic. It's chronic. It goes on and on. Chronic pain can be further divided into 2 categories, known as chronic malignant pain and chronic non-malignant pain. These 2 types of pain categories are associated with diagnoses like leukemia and cancer and its treatments. Chronic malignant pain is expected to end either by cure or death. Chronic non-malignant pain has no predictable ending. You've heard of people that describe lower back pain from years of repetitive movements or leaning forward or imperfect posture or carrying heavy loads or whatever. And that can go on throughout their lifetime. Pain type, a second method for classifying pain, is the type of pain. There is somatic, pain, visceral, bone pain rather, sorry, and neuropathic. Okay, neuropathic has to do with our nerves, our neurons, the signals from our brain. Bone pain has everything to do with our bones. Visceral is everything on the, like our skin type. If you touch the skin, like when you get a bad sunburn, that's visceral. Somatic pain is if someone has gets burned and you feel their pain, that's somatic pain. Or if you are um, um, in a relationship and the other person is pregnant and they're feeling painful and you take on some of that pain, it's not uncommon for some people in relationships to go through some of the same um, pregnancy discomforts. And that is somatic pain. Visceral is associated with the internal organs and also what you feel when you press in. Bone pain is caused by the sensitive nerve fibers. And I'm not sure what that little typo is. And the outer surface of bone. And lastly, neuropathic pain comes from nerves and nerve damage. Outcomes of untreated or unrelieved pain. The body experiences pain and when it's important in avoiding physical harm. Like if you touch or get close to a heated iron and you pull back, then you can, or if you're pounding nails and you miss the nail and you hammer your finger, that's a painful event. Unrelieved pain, however, can be harmful both psychologically and physiologically. It actually weakens your immune system to have prolonged unrelieved pain. The perception of pain can be increased by heightened fear and anxiety. Neonates are especially at risk, according to Anand from your book, because they experience increased sensitivity to pain compared to older children. They're smaller beings, things are more compounded, or they're more compounded because they're a smaller individual. And if they experience pain like a needle poke or something like that, they just experience it at a larger intensity than an older child would. The neonate brain is considered plastic or malleable, creating a vulnerability to early adverse experiences. Repeated exposure to pain can develop altered pain sensitivity, anxieties, stress disorders, hyperactivity, and attention deficit disorder. Excuse me. Impaired social skills and patterns of self-destructive behavior. When we assess children's pain, there are 3 categories of behavioral indicators used to assess children's pain. The first one is a global rating scale that relies on assessment of predictable behavioral indicators of such pain. So, of pain such as crying, wincing, knitting the eyebrows, screaming. Number 2, indirect measures of pain, such as requests for medication or well behavior, such as playing. The third is behavioral observation scales, which focus on documentation of specific behaviors indicative of pain. And I would like to switch to, I want to switch real quick to one of the pain scales in this lecture. These are the pain scales that we use in the hospital. This is called the Wong-Baker pain scale, and it's used primarily in pediatrics, or it's called the FACE scale. And we just show the card to children, and they point to the one that most resembles the amount of pain that they are feeling. No hurt, a happy face. They're starting to grimace at 5 and 6. 8, they're frowning, and by 10, they're crying. It's the worst pain. And then as children age up a little bit, we use this inverted pyramid because older children can conceptualize a little bit better that this means the least amount of pain, and this means the most pain that they've ever experienced, okay? So these are 2 universal pain scales that are used in healthcare worldwide. And they are important in this lecture because we're going to actually have you make your very own pain scale later. Okay, hang on one second here. I don't want you to get dizzy. So when we assess children's pain, we use that patient self-report and behavioral observation technique. We show them the card, and we want to make sure that what they describe or what they point to is also mimicking or mirroring their behavioral cues. Are they in a fetal position? Are they crying? Are they moaning? That sort of thing. So those are physiologic measures, and then in addition, heart rate and blood pressure can increase when children are in pain, and those are definite indicators that a child is having a painful episode. Assessing pain in children can be challenging due to the fact that it is very subjective. Not every child can communicate well the amount of pain that they're in. For infants, there are observational cues such as they get sweaty and pale, or they're not eating, they're not acting themselves, they're not sleeping well, they're crying in distress. For toddlers, their language skills provide additional cues for perceived pain. Some toddlers become quiet, inactive, or very active from fear of perceived painful events. Sometimes they get in their hospital cribs, they get a little bit super active, almost as if they're trying to escape. And there is nowhere to go, basically. And I'm sorry about this typo. That means school-age children. They rely on describing the pain and the location and are quite capable of great self-control, holding their breath, blowing out imaginary candles, using distraction techniques to blow the pain away, or close their eyes and think of a happy place. With adolescents, it can accurately describe pain, its intensity, and the location, and they may exhibit a high degree of control. There are other influences on children's responses to pain. Child's coping style. There are 2 basic types of coping styles: attenders or monitors, who are information seeking. And they may ask a lot of questions, go on the internet, things like that. And then there are distractors or blunters. They want to diminish the pain, who are information avoiding. They may not want to know any techniques to close their eyes, say ouch, 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 look away, hold someone's hand, things like that. Another influence is the past experience of pain. that a children has endured. Children remember painful experiences, which can alter their response to the perception of painful experiences. So in other words, if a child is on his way to a doctor's office for immunizations going back to school, in order to go back to school, they will ask repeatedly, do I need a shot? Do I have to have a shot? Because they remember the last time that was something they had no control over, and it was, and injections can be, the first poke can be painful. There are family and cultural styles, family beliefs, attitudes, and parental pain history can influence how children learn about pain, its impact, and how to cope with it. Children look to parents during a painful situation to learn how to react. And if they are being told, you want to just don't be a baby, don't cry, take it like a man, things like that, that can be helpful. It can be damaging because children need to be able to emote, cry, grimace, express their pain if that is the situation. And then another influence are situational factors. And McGrath in your book cites 3 specific factors related to how children experience pain. What the child and the parent understands, what they do, which means like, do they hold still or are they wiggling around? And also how the healthcare staff handles the situation. If the healthcare staff says something like, if you don't hold still, I will have to poke you again, that reinforces pain or injections as a punishment, and that's not okay. And then how children and parents feel. Now, just a tidbit about chronic pain. Children with chronic pain that goes on tend to have more anxious, internalizing characteristics than externalizing problems. Biological and psychological characteristics are believed to play an interactive role in the experience and the expression of pain, and are likely to contribute to gender differences in adjustment and coping responses. And then the ways children cope with chronic pain is believed to play an important role in healthcare-related outcomes, such as pain intensity and the functional disability from that pain. A recent study, not so recent actually, by Lynch, found girls used social support more than boys, who used more behavioral distraction techniques. And adolescents engaged in more positive self-statements than younger children. But I have also met some very prolific advocates in the younger population that have learned techniques from their parents or from, I don't want to be so bold to say child life necessarily, but, and little kids can say, I can do this, I can do this. And that's positive self-talk. So, I mean, younger children will surprise you on how much they can do to distract themselves, or that positive self-talk. Some special considerations. There are medications available to help children manage pain. And the only issue with some of these medications, there's something called EMLA or LMX cream. And it is, say for instance, you're going to have an IV on your hand. So they can put this cream on your hand, cover it with a Tegaderm bandage, and let the cream sit for 30 minutes before the event. And it numbs the skin. It is not always used because not every event has a 30-minute lag time before they're going to start an IV or what have you. There is something called cold spray. And then we also use something called Buzzy, which is it's about the size of a kiwi. It's a ladybug and it's flat, and a doctor actually developed this. And you put the little ladybug between the pain, say you're going to have pain in your wrist or your hand, and the brain. So you put it somewhere up here and the child can hold the little ladybug. It's a plastic ladybug. And then they can turn on the vibration, and the vibration confuses the brain to think about only the vibration and nothing else going on here. So it's a really great empowerment technique that we use with children, and we will ask them, have you heard of Buzzy? Would you like to try it? Do you want to use it? And then we wait until they can tell us whether it was useful or not. And sometimes they just like to play with it. And this is kind of a behavioral technique that can distract children during painful procedures. And it also alleviates fear and anxiety. Children respond to pain control strategies that involve their imaginations and senses of play. And the more that they can be involved in holding a stress ball or a stretchy string, worm, or we have these light spinners that they can press and they light up and it moves around. There's vibration and it's really cool. Things like that almost feel like play, but it is actually a distraction technique. In an emergency setting, children prefer music to toys. And hypnosis provides an altered state of consciousness. We can talk a child through a visual imagery session to help relax them by having them close their eyes, and then we will help them relax from their toes to their temples. And the relaxation techniques that we use, they're called guided imagery exercises, and we can ask a child a couple of questions before we begin of where's your happy place, what helps to relax you, whether it's listening to raindrops on the window or if it's sticking your toes in the warm sand at the ocean, hearing the seagulls and the waves crashing and all of that. And so we can use a lot of very colorful language to illustrate their happy place and help to relax them. And then another technique is biofeedback, which is a pain relief mechanism based on specific physiologic changes caused by biofeedback. And you have to be hooked up to electrodes, and you can learn to train your brain basically to get into a calmer state. I don't remember what type of wave. I don't know if it's alpha or beta or what have you waves, but biofeedback is really helpful. I've actually been through sessions of biofeedback for migraines when I was much younger, and it really helped. And you can learn to train yourself to go to that place, close your eyes without the biofeedback machines, to alleviate that pain and that stress and so forth. I'm not going to really go through this in depth. I'm just going to state that these are suggested interventions dependent on the developmental stage from infant to adolescence, and what works best. Okay, so you can kind of look at that on your own. And then this is the activity for today. It's called a pain thermometer. And this is essentially what it looks like. If you have access to any Band-Aids, and I'll put it close, I call it the ouch scale. And this means just a little pain, some pain. The bigger the bandage, the more pain it is. and a lot of pain. And then at the bottom, it says, how much does it hurt? So if you have Band-Aids, that's great. You can create an ouch scale. I selected some Band-Aids from my first aid kit at home. There's a really big bandage in the back, and then there are two bandage strips, and then one of those round ones. Or if you don't have Band-Aids available, you can draw them on a piece of paper, and that works too. So let me go back and cover the other lecture. And this is about, this is a breathing lecture. Chapter 13. And there are children admitted with diagnoses for asthma, cystic fibrosis, upper respiratory illnesses, things like that, where breathing, it can be labored and painful and difficult. Some of the most common health problems in childhood are related to respiratory function, with respiratory infections accounting for the major or majority of acute short-term illnesses. Respiratory distress is the 8th leading cause of death in newborns, with pneumonia ranking in the top 10 causes of death. Pneumonia, rather. When designing activities for children with airway impairment, it's wise not to overstimulate their already compromised and delicate respiratory system. So you want to choose activities that don't require a lot of expiration, okay? Inhalation and expiration. It's important for children who have respiratory problems to have information about their illness. Therefore, activities can be tailored to increase understanding and education. And that's really what the primary goal of any activity. You want to be able to increase their understanding and add to their education about what is going on through the activity. And respiratory problems can be caused by trauma, disease, or physical anomalies, things like that. Understanding respiratory problems. Asthma, it's a chronic disease characterized by recurrent attacks of breathlessness, wheezing, and is the most common chronic disease among children, according to the World Health Organization. Although the cause is unknown, it is thought that genetic predisposition and environmental factors play a part. Feelings of isolation and loneliness are common when a child is unable to keep up with their peers. They may fear death, and that can be a common factor. Irritants in the environment may exacerbate symptoms. Pet dander, vegetation, toys, certain dyes in clothing, in foods, secondary smoke are all possible irritants. Another disease involving respiratory system is cystic fibrosis. It's an inherited disease that causes the individual to cough with a productive reflex or protective, with a productive sputum. It's also a protective reflex, that coughing, all right? That protective reflex in a cystic fibrosis patient helps them to try to bring up some of the gunk in their chest, so that it frees up lung space where they can take a deeper breath and get oxygen in. Environmental factors have become a growing concern for children's health. Secondhand smoke's been found to cause adverse respiratory consequences, including early onset asthma in young children. Secondhand smoke increases coughing and wheezing, airway obstruction, airway hyperactivity, and often bronchiolitis. Another risk factor is sudden infant death syndrome, or what is called SIDS. According to Fleming and Blair, Pollock, Weisborg, and so on and so forth. So sudden infant death syndrome was on the rise about 4 decades ago, because parents didn't know any better and put infants on their tummies or their side or what have you. And truly, infants should be on their back, so that they don't roll over onto their tummy, and which is when they can suffocate. SIDS is also, it can be a sudden infant death. It can be an immature respiratory system. It can be something completely unrelated to, a child rolling over onto their tummy and suffocating. It can be a birth anomaly. It can be an immature lung. It can be, other issues. Post-operative respiratory problems can occur. So often following any anesthesia,